Great. Okay. So welcome everyone to this very first web seminar on that is promoted by EUPSA, and it's one of the first one of a series. So far, as far as we know, it's gonna keep us entertained up until December. So for the next 3-4 months, and this is. We've decided with, this is Martin's idea, and Martin and I chosen some topics that are, I think, interesting for many of us. They're still quite controversial. And today, specifically, we are talking about necrotizing enterocolitis. And there's one of the most controversial aspects of this condition for us surgeons is whether to place an intraperitoneal drain or whether to do a laparotomy, especially when these preterm babies are very tiny. So I'm sure there's going to be a very nice discussion. So the first discussant is Professor Martin Lacher. Martin received his medicine degree from the University of Cologne, but he did also training in general surgery and pediatric surgery in Germany, but at the same time studied for the US medical licensing exam, the USMLE, and so spent 2 years in Birmingham, Alabama for a fellowship in pediatric surgery, and got back to Europe, unlike me so far, and was in Hanover for some time, and he's been the chief of pediatric surgery in Leipzig, and the director of the Department of Pediatric Surgery at the University of Leipzig since October 2015. So it's almost 5 years. I think, Martin, your main interests are, of course, in neonatal surgery, inflammatory bowel disease, and colorectal surgery in general, isn't it?
Yes. Thank you, Augusto.
Martin is going to present the laparotomy option for babies with necrotizing enterocolitis, whereas then Oliver Münsterer will present the intraperitoneal drain option. So we have.
Thanks for joining this webinar on necrotizing enterocolitis, and my part is to talk pro laparotomy. If you have a question, maybe you just type it in the chat, and Augusto can later moderate the question and answer section. So my talk is about 12 minutes. The indication for surgery is absolute indication if you have pneumoperitoneum or free air. However, there are also relative indications for surgery in case of portal venous gas, a shiny distended erythematous abdomen, or rapid clinical deterioration. This is a study from 2014 showing that mortality decreases with increasing birth weight. In black is surgical neck, in gray is medical neck, and you see the extreme low birth weight infants, those are the ones who do not survive possibly 1 year after discharge. So I want to start with a case scenario. Let's take this baby you see in the ICU, 520 gram, and you obtain an X-ray showing pneumoperitoneum. For some reason, the neonatologist put some contrast in, and leukocytes are elevated, CRP is elevated, thrombocytes are falling. You started catecholamines. Now the question is, do you do laparotomy or do you just put in a drain? Let's look at the data. There are 2 randomized controlled trials out there. The first one is the Next Steps trial with 117 patients, babies below 1.5 kilos. And you see that the mortality in the lab group was 36% and in the drain group was 35%. And another randomized control trial from Europe, the NET trial, 68 patients, they looked at babies only below 1 kilogram of birth weight And they had a mortality in the laparotomy group of 36% compared to 49% in the drain group. So overall, there were no difference in mortality, no significant differences in those two randomized controlled trials, and no difference in days on TPN and length of stay. Of note, in the NEC trial, in 74%, so 3 out of 4 children underwent a secondary laparotomy after 2.5 days. That's why in the discussion of these papers, the authors discussed whether primary peritoneal drain might be ineffective. And to me also, this high rate of secondary laparotomies is a high rate for a method that obviously does not improve outcome. So the question is, what is good, what is better, what is best for this case scenario? I favor laparotomy in these babies. You can see here, this is the technique that is most commonly used by most surgeons, a transverse incision in the right upper quadrant. And what I want to show you with this image is that you can leave the venous central line in the umbilical vein in place. It is not a laparotomy going from xiphoid to symphysis, so it's really only a 2 centimeter limited laparotomy, which can be done in even small babies as this one here. And then this is after placing the stoma bag over the ostomy that was created. To me, the biggest disadvantage of a drain is, and that's why I do not favor this, it's a black box if you put a drain in. The advantages of laparotomy is that you get a definitive diagnosis. Let's look at the patients of the European trial, the NET trial, in these patients below 1 kilogram of birth weight. Those were the intraoperative findings. In the left column, the laparotomy group, in the right column, the peritoneal drain and secondary laparotomy group. And you see that it is not only NEC, it is FIP, focal NEC, diffuse NEC, and panintestinal NEC. So without laparotomy, you do not know what you're dealing with. You can have, for example, find this. This is a multi-segment NEC with massive pneumatosis. This is another multi-segment NEC. This is NEC in the colon, which is found in cardiac patients most of the time with the transmural necrosis. You would not see this with a drain. Panintestinal NEC, like seen here with a bowel that is not perfused anymore, you would not see this with a drain. Multisegmental up to almost panintestinal NEC. So the question is, who would put a drain in this patient and just await for the necrosis to be liquid and then be drained via this drain? Or would you opt for segmental resection? Or this patient with a typical FIP picture that you can appreciate and then create an ostomy or even shoot for primary anastomosis. In this patient, for example, it's also FIP. We just oversaw the 2 holes and did a primary anastomosis. Also, it is not always NEC or FIP. It can be something completely different. Let's take this baby. Pneumoperitoneum, distended abdomen in the NICU, and you obtain this X-ray. So if you would have put a drain in here, maybe would not have helped, because on laparotomy, you appreciate it's the NG tube perforating the stomach. And you all know that stomach perforation has a really high mortality. So just putting in a drain, you miss pathology that is neither NEC nor FIP. This patient, we oversaw the stomach perforation, and then the baby recovered pretty well. So taking together advantages of laparotomy, apart from the diagnosis, is you can resect the necrotic bowel, you can irrigate the abdomen, irrigate all the stool out of the peritoneal cavity, and the laparotomy can happen in the NICU. In older times, this image was taken a very low birth weight neonate surgery in the OR. Of course, this is not so ideal. You have to go to the OR, you have to place the baby on the OR table. However, there is data that is beneficial to do the laparoscopy in the NICU. This is a study from Taiwan, 92 neonates, and surgery was done in the NICU in 44 babies and in the OR in 48. And the OR group had a higher incidence of hypothermia compared to the NICU group, 65% versus only 9% in the NICU. This is the video how we do it in the NICU. So the baby is actually left in the incubator, is not moved anywhere. And I think this is a sort of minimal handling that you can easily do. And the baby does not undergo hypothermia. And this is the way we do it. And of note, there's no data actually until now comparing laparotomy in the NICU versus drain in the NICU. I would be very curious what would happen if you would compare those two. Apart from the randomized controlled trials, this study I cited before, 655 US centers looking at survival 1 year after discharge in a significant number of patients. Laparotomy only 30% mortality, peritoneal drain and laparotomy 35% mortality, and the highest mortality was seen if only a drain was put in without laparotomy. However, if you look at the data, there's a this year first meta-analysis comparing drain and laparotomy. And to be honest, if you look at all babies below 2.5 kilo, there's, apart from the 2 randomized controlled trials that I explained already, 25 observational studies with 13, which they defined as high quality of reporting. And these meta-analysis showed that the mortality between the 2 techniques actually is equal. However, looking again at the secondary laparotomy rate, it's up to 50% after laparotomy that you have to choose a second look laparotomy. But if you put in a drain, it is up to 100%. So to summarize my talk, laparotomy versus drain, there are 2 randomized controlled trials out there and 1 meta-analysis showing that the mortality is equal. The NET trial had a significant number of secondary laparotomy, 3 out of 4 children. And the largest cohort study so far showed that the drain alone without secondary laparotomy has the highest mortality. So to me, laparotomy gives you a definitive diagnosis, possibility of resect the necrosis and irrigate the abdomen. And laparotomy in the NICU is possible. So to conclude, laparotomy to me is a surgical technique for diagnosis and treatment in case of pneumoperitoneum, also in very low birth weight infants. Thank you very much.
Thank you, Martin. It was very clear. You did your medical degree in Alicante, Spain, but also in Munich, Germany.
That's right, yeah.
You trained in general surgery in the Washington Hospital Center in Washington, D.C., and you did your pediatric residency at Duke in Durham, North Carolina. And you then were in Munich and then also in Alabama to do your pediatric endosurgery fellowship. So you board certified in the US as well as in Germany. And you served as a staff pediatric surgeon at the University of Leipzig before becoming an assistant professor of pediatric surgery at the University of Alabama in Birmingham. And then you moved on to New York, the USA in 2011.
And then I went on to Mainz. Just cut it short because.
Can I say where I heard the rumors that I don't think it's a rumor anymore that you are going south.
Yeah, that's true.
And you're going to be the chief of pediatric surgery in Munich.
Starting next or month after next in October. Yeah, exactly.
congratulations. That's it's a beautiful city. It's in a great center. So congratulations to you.
Well, thank you so much.
And so you're going to tell us about the intraperitoneal drain option.
Okay, let me see if I can share my slides. You got to tell me if you can see anything. Like, do you see anything?
Yeah, we do.
Okay, and then I'm gonna start the presentation. Do you see my presentation?
Yes, beautiful. Yes.
Okay, so my job today is to tell you why you should not perform an operation, which for a pediatric surgeon is kind of an interesting perspective, you know, and rather place a drain. So Martin gave a wonderful overview talk, and I'm just going to use that to look at the arguments against operation. So we all know these babies, and we look at them, and we wonder, you know, how can we really help these kids? And there's a lot of unknowns in this disease, as you all know. I mean, the first thing that I always wonder is, when should we operate? I mean, you know, it's easy if it's free air like here, but more often than not, you do not have a clear, you know, indication of free air. You have these kids that have Bell stage 2 NEC, and their platelets drop, and they're not doing well, and you know, and you just wonder, when should we do something? Which operation should we perform? You know, it's not very clear. Should we do this minimal invasive laparotomy that Martin says? I think that's very difficult to get at all the bowel. If you really want to look at all the bowel aspects, like the colon and the small bowel in its entirety, you probably need a little bit larger incision than Martin alluded to. If we are in there and you have the bowel in front of you, so should we resect the bowel or should we just divert? If we resect, how much should we resect? Should we do an ostomy? Should we do an anastomosis? If we do an ostomy, what kind should we do and where should we place it? So there's all these different, you know, these unknowns. And more often than not, I was faced with this kind of situation where there's obviously dead bowel. There's also some, you know, live bowel, and you don't want to resect more than you need to. But, you know, how do you deal with this? Do you just take little pieces off and have these other pieces that you put together? You know, it's not very clear. So the disadvantages of a laparotomy, in my opinion, are that you need to do this under anesthesia. So you're subjecting the kid, who's in a dire situation anyhow, to one more stressor. Martin already said, you're going to subject them to hypothermia. You might be able to do it in the intensive care unit, but let's face it, a lot of intensive care units are not operating rooms. They do not have all the equipment that we need, and they're just not optimal for a large operation such as laparotomy. There's the surgical stress that you're producing. You may resect more bowel than is necessary, and that will leave the kid with short bowel syndrome. Finally, if you do elect to place an ostomy, we all know that ostomies are not, you know, just easy things. They have complications, and if you do ostomies, you're going to have to deal with the complications. If you do an anastomosis, it's even worse, because anastomosis can fall apart in the middle of the night. They can, you know, 5 days later, the baby's doing really badly, and you don't have no clue what's going on, and you hope that your anastomosis is fine, but you don't know. You can't look inside. And then if you do perform an ostomy, you're going to do another operation, because you're going to have to put it back and do an ostomy takedown. So all these things are really disadvantages of going in a laparotomy. So, you know, I understand that argument with the black box. You don't know, but really, is that all we have to do? Is really knowing all that we want? I mean, in the end, what really counts is outcome, right? All we want is our babies to do, our patients to do well. And whatever means need to be undertaken to reach that goal. So let's look at the history of the neck drain, which is incredibly fascinating. So Siggy Ian in Toronto started this, and Augusto, I know you're there, so you're going to be proud of this. And this is their first diagram that they published in 1977, and they figured, and the way they looked at it is they had these really, really sick babies, and they said, well, if we take them to the operating room, at that time, I don't think it was an option to operate them in an NICU. You know, we're going to create more trauma. We're going to subject them to a larger risk than if we don't do anything. How about we just drain them? We decompress their bellies, and then we'll see if they get better. And that was the initial way or the initial approach. So this, whatever you want to call it, intervention operation can be done in the NICU. It can be done in about 10 minutes. And oddly enough, the only video I have is actually a video that I have from Martin. And this is actually Martin's video that he lent me, which I'm very grateful for. And you can see how this kid with neck has a distended abdomen, and they're going in and they're perforating into the abdomen. And now something really interesting happens, because the decompression, you can see the decompression and the air coming out here, and how the belly suddenly goes from shiny to sort of, you know, non-shiny, like rugated. And some of the stuff is coming out, mainly air. I bet this was just a simple perforation. And that's all there is. And then you put in the drain, and that's it. Now, the difference in the technique in this video, I usually do it from the right side, right lower quadrant. I think you could probably do it from the left side. I know people have done it through the umbilicus, because they feel that that leaves them with less of a scar. I've never done that because I'm kind of afraid of the liver bleeding when I do that. I must say the left lower quadrant is nice because it spares the liver. However, most of the problem in neck and FIP and that kind of thing is in the right lower quadrant. So that's why I go in the right lower quadrant very carefully. So this is the first Toronto paper that they published, because then they looked, after like 13 years of doing this, they actually looked at their outcome. And what was really, you know, they had a 57% survival rate of the 37 neonates that they performed peritoneal drain in. And what is really striking is that 1/3 had complete GI recovery without any other operation. And I think that is spectacular. And that's why I like the drain. I know I can't help them all with the drain, but I can help a significant portion with them, and they will start pooping again and will not have a bowel obstruction and will be fine. And that, I think, is one of the big reasons why I like the drain. I want to give them that chance. Now, later on, the guys here looked at salvage laparotomy. So, you know, in those that didn't get better, some of them underwent salvage laparotomy. And they looked at this early on in around 2000, so it's 20 years ago. They looked at 26 extreme low birth weight preemies, and just looked at the ones that only got a drain and the ones that had salvage laparotomy. And the ones that had the laparotomy were actually larger, you know, and they had more, and the ones with the drain had more comorbidities. So you would expect the ones with the drain to do worse. But in fact, there was no difference and in statistical difference. And actually 4 of the deaths were in the salvage lap group. So they concluded that there was no advantage of salvage laparotomy. And we're not talking about a laparotomy you know, weeks after when they develop a bowel obstruction or something, or a stricture. We're talking about those that had a programmed operation after a peritoneal drain placement. Now, I'm going to go over this really quick because Martin already talked about it. This is the Moss study. It was the first prospective randomized controlled trial on this. 15 centers, 117 patients, under 1,500 grams. In this study, crossover was allowed, but it was discouraged. So if you were randomized to drain placement, they did not encourage you to switch to the other group. And the outcome variables that they looked at is survival after 19 days and TPN dependence after 19 days. And this is the flow chart, and you've already heard some of these from Martin. And but the point that I want to make is that only 5 patients crossed over in this study design. That's important because it's different than the European study. And you can see the Kaplan-Meier curves here. And in fact, in mortality, there was no difference in long-term outcome. What about TPN dependence? Absolutely no difference between whether you put a drain in or you do laparotomy. No difference. So the second randomized controlled study, as we already heard, was done in Europe, 31 centers, 13 countries. They had a little bit different patients. They lowered the inclusion weight to under 1,000 grams, and they explicitly allowed crossover. And this is one of the key kickers that I want to stress here. So the outcome variables were also a little bit different. They focus on physiology and organ failure scales, and this is their flow chart. And there were a lot more crossovers than in the Moss trial. But if you look at the demographics, there was no different. And so the kicker was that they allowed the patients to cross over, and because there was no stabilization after drain placement, no significant improvement, so a lot of these surgeons had the bias that they had to do something. So over 47% of the patients had a salvage laparotomy, even though they were randomized about 50-50. And so the conclusion of this study was that early primary operation is recommended because a lot of these patients had an early primary laparotomy or needed a salvage laparotomy, needed in parentheses. But in fact, there was no difference in survival, and there was no difference in the other parameters. So here's the difference. Here, the salvage laparotomy in the Moss group were 9%, but they were 74% in the Reese group. And I believe that that's just simply bias, pre-study bias of the participating surgeons. And that's why, you know, you had all the laparotomies, and then everybody said, oh, you need a laparotomy, you know? So it's basically the same outcome, but a different interpretation. So why do people think that we should perform a laparotomy and take out dead gut? And I think that is based on this study that came up because they looked at what happens in neck, and they looked at the different inflammatory cytokines that are released, and they found that more cytokines were released in neck. And they conclude that we believe that primary laparotomy is associated with more optimal neurodevelopmental development because it prevents the sustained injurious effects of the remaining disease and necrotic bowel on the newborn brain. So basically, because you have necrotic bowel in there, that produces cytokines, and that somehow has a bad influence on the brain. So I looked at this study, and the reason that they base it on this, the only reference that they list in that regard is this study from 2006. So this is a study that was published in Pediatrics, and it compared laparotomy versus peritoneal drain placement. And the interesting thing about this study, and I must say it's a very, very good study in this sense, is that it looked at outcomes, neurodevelopmental outcomes. So it was a prospective cohort study in 16 centers of overall almost 3,000 ELBW patients. It was non-randomized, and that's one of the real drawbacks of the study. 156 had either necrotizing enterocolitis or focal intestinal perforation, and 80 of these were treated by a peritoneal drain, and 76 were treated by primary laparotomy. And the outcome variables in this study were mortality, TPN dependence, again, after 85 days. Why they didn't use 90 days, I don't know. It would have been more comparable to the Moss trial and everything. And this is the difference, and you have to really congratulate the authors for this. They looked at very carefully at neurodevelopmental scores at a corrected age of 18 to 22 months. So if you look at that, this here is the flow chart. And basically on the left, you see the ones that had the drain placement, and on the right, you see the laparotomy ones. And the ones that survived with neurodevelopmental outcome were significantly higher, 63% in the drain group than in the laparotomy group. So you would conclude, if you just looked at this, you would say, well, the ones that were underwent a laparotomy are doing much better neurodevelopmentally. However, and it was not randomized, and this is why where the flaws of this study. So if you look at the groups, they are not equal. So the ones that got the drain were significantly smaller, they were significantly lighter, and they were younger when the operation was performed, and this is all significant. They also had more vasopressor use, they had lower blood pressure rates, they had higher ventilator rates, they had more FiO2. So basically, these were the sicker kids. The sicker kids got the drain, and the sicker kid had a worse neurodevelopmental outcome. So that does not surprise anybody, and that is the problem that this other study is based on. If you just read the study, you would think, okay, you know, they have worse neurodevelopmental outcome. So there are actually some recent studies that put another look at the whole thing. There is one study that came out in 2007 and that was a prospective matched pair analysis, and they actually matched for 48 factors. So it was very cleverly and diligently done. They looked at a database of ELBW patients below 1,000 grams, and the outcome variables were mortality, length of stay, and total treatment costs. And I'm saying this is a prospective study because they, of course, looked at the database, but they prospectively did the match pair analysis. So these are the data, and you see the peritoneal drain group on the left, the laparotomy group on the right. And here you actually see that the survival was worse in the laparotomy group, significantly worse. And this is also true if you looked at the ones that had a drain and a later laparotomy. And if you look at the ones that had salvage laparotomy, it is no difference. Okay, so so the drain was the primary thing, but if you only look at laparotomy, they had worse outcome in terms of survival. So there's another study that just came out 2019, last year, looking at the initial surgery for necrotizing enterocolitis, and they also compared this in below 1,000 gram birth weight infants. This was a retrospective study from the Children's National Database. They looked at preemies under 32 weeks, and they did multi-regression analysis for on a number of factors, and looked at mortalities, short bowel syndrome, and length of stay, and basically compared these factors for laparoscopic and drain. And this is here the outcome. The lap group was significantly larger, you have to say, than the drain group, but the outcome in this, everything is basically the same, but survival, but the lap group had a higher rate of short bowel syndrome, which I interpret that if you perform laparotomy, you are more likely to resect bowel, and that may lead to higher rates of short bowel syndrome afterwards. That's my interpretation of this. So what would you do? It's really, if you look at the data, the randomized controlled trial, I think what we can say is no matter what you do, the outcome is pretty much the same. And I must say, if you have the same outcome, then I think you're ethically and morally obliged to do the less invasive, less harmful procedure, because first of all and foremost, we are there to not do any harm. And therefore, my idea is to go and do the peritoneal drain placement, and not worry about not knowing what's in the black box. If you have the same outcome, use the least invasive tool you have to get that particular result. Thank you very much. And this is my team here in Corona times, of course. Thank you so much. And I'm looking forward to taking your call, your questions.
Thank you. Is there any case in which, for Martin, in which you use the drain? Is there any exception that you make to your rule of the laparotomy?
Right. As Oliver said, that one video that we shared, that was a kid with extreme prematurity, 420 gram and free air and very unstable. So if we talk to our neonatologist and we agree that the baby is too unstable for laparotomy, and we think this is like a procedure that should only take, as Oliver said, 5 to 10 minutes to bridge the baby to a time point where a laparotomy is survivable, then this would be an indication to put a drain in. However, also in that baby, 2 weeks later, we opted for laparotomy because the continuity was not reestablished. So to answer your question, the extreme unstable child.
Because I'm in Toronto, which is where the drain was first invented, but I trained in the UK, and so I'm a big proponent of the laparotomy, and I try to avoid the drain. But as everything, it's not always black and white. What I've learned over time is that, for instance, and we go back to the neurodevelopmental outcomes that Oliver was mentioning, there are some babies that do have already a bad picture of the brain ultrasound, and this is one of these situations in which maybe we have a conversation with the family, let's say like a bilateral grade 3 or grade 4 IVH, and sometimes after the conversation with the family actually opts for the least invasive thing. And that would be the drain, or from transport, that would be another one. And another question, because we are still during the pandemic, has the pandemic changed your management now that we try to minimize the risks of spreading the virus? Have you, I know that in some places certain operations have been done less, or have been converted from laparoscopic to open, like the appendectomies, or for appendicitis, there are some centers that opted for non-operative management. Would you consider a drain to avoid being in the OR with NEC because of possible COVID? You don't get the results of COVID right away. Would it be something that also you would consider?
To me, no. Clear no. We do not consider COVID. I don't even know whether we test our preemies. I would say we don't, but I don't know. Maybe other answers. Possible.
Well, I think that's a theoretical risk that really you don't have to look at, because I mean the spread of any bodily fluids from a preemie is probably minimal. I don't think anybody has ever recorded a COVID transmission from a preemie or from a baby even. You know, and personally, I still do all my operations minimally invasive. I don't see a reason not to. In fact, we screen everybody that comes to our ward, and maybe we're also very fortunate. I mean, we have an exceedingly low rate of COVID.
Same experience here. We're still doing minimally invasive surgery and all the rest. But I know that there are places where they've changed their attitude.
But
Nigel,
why?
There's that's maybe for another discussion. But no, but I agree. For babies, is definitely I wouldn't consider it. So Nigel has his hand up. Nigel Hall from Southampton has definitely contributed to the literature on NEC. You want to ask a question, Nigel? He's muted. You're muted. We don't hear you. Okay. Well, he gets ready. And going back to laparotomy, Martin, what's your attitude? Do you do a if you can, you do an anastomosis, a primary anastomosis, or do you prefer to do a stoma for these little ones with perforated neck?
With perforated neck, we almost exclusively go for a stoma. I also think a laparotomy, as I said, is not laparotomy. So if you do a laparotomy in an extremely low birth weight infant and you need, like, for example, 1.5 hours, that would definitely maybe harm the child. So you have to be fast. You have to look where the perforation is and then do an ostomy very quick. I think to be fast, not injuring the liver, that's key. I only may consider primary anastomosis in FIP, but in NEC, never.
Okay. Any questions? I still see Nigel's hand up, but he's not.
Goncha has a question in the chat.
Okay, Goncha's a question. Does anyone prefer to use the clip and drop technique?
Yeah.
And there's another question, in fact, also from Dr. Dionysis. What is the opinion of the podium for clip and drop in very low birth weight?
Well, I don't need to even think about it because I don't have a look at the bowel, so I guess I don't.
If you survive the drain.
Yeah.
So, well, I think clip and drop is certainly an option. However, the disadvantage is if you just clip and drop, you cannot use the bowel, obviously. If you put multiple ostomies, you can refeed and try to limit fluid losses. So, but yes, it's always an option. Yeah.
Okay. I guess the other, you know, the question, the counter question to Martin would be, when do I do a laparotomy? And the answer there is, if I suspect pan neck. Okay?
That was my question to you. Exactly. How long do you feel? So here, there's a lot of my colleagues that do use the drain, and there's some that use the drain, you know, and just as a temporizing measure for 24, 48 hours, and then they go in. Others instead use the drain and leave it there for up until there is discharge, and then they shorten the drain, and then they remove it. And then they might see if the baby tolerates feeds or doesn't have pilus aspirates, they might start feeds. What's your approach?
So my approach is pretty much what you said a little later. So I put in a drain, I leave it in till it stops having any discharge. and then I might either take it out in a little, just shorten it a little bit, or I just might take it out completely. And then I'll wait till if the kid starts having bowel movements and there's no bilious drainage from the NG tube, I would start feeds. And if not, then then after a few days, weeks, 2-3 weeks, I would go in and look at what the problem is. If I suspect hand neck right in the beginning, I will do a laparotomy. And my reason is because with a drain, they may linger for a long, long, long time and then die. And I'd like to give I'd like to take that off the table. So, it's hard. Sometimes you just have the feeling this kid is so sick that, not even a drain will help. And then I might open up just to have a look. And if it's pan neck, I might just close the abdomen and tell the parents that this is nothing that can be surgically solved.
Another question for you regarding the drain. Do you use one drain or two drains, the right, left?
I usually use right lower quadrant one drain that I try to bring across the midline, sparing the liver. I know some people use like a sort of loop drain in the right lower quadrant, out the left lower quadrant. Martin uses the left lower quadrant. I had a colleague in New York who always put the drain through the belly button. I kind of found that daunting, but of course interesting because you avoid another scar. And, and honestly, one of the complications of drain placements, they do get hernias there. And more often, I can say that, but in some kids, I have to go in later on when they're a year old and fix a little abdominal wall hernia.
Okay. And there was a question earlier on about gangrenous bowel. Is there a role for closing the abdomen? So I assume that the question is for someone who doesn't get either the drain or but gets the laparotomy, closing the bowel and having a second look surgery a couple of days later. Martin.
Well, you can certainly do this. However, it's another trauma. I prefer to create an ostomy upstream of all the bowel that's not looking good. So most of the time it's in the TI, terminal ileum. So if you create an ostomy upstream, I don't really care about the gangrenous bowel downstream. That can stricture, they can die, and you address that later when you want to go for ostomy takedown and reestablishment of bowel continuity. So, but certainly if the child deteriorates, you can go for a second look. But prior to resection, it has to be really necrosis and not just dusky, bad looking bowel.
And for Oliver, what is, so in a case of a kid that is not perforated, is doing pretty, is still on anitropes, is not improving, and you think that the kid is actually failing the medical management. So it's like 24, 48 hours after, still on anitropes, oscillated, looking bad, but there's no, on X-ray or ultrasound if you want, there's no free air. Would you still consider a drain in those cases?
That's a great question. And really, in my opinion, if there's free air, there's no doubt something has to be done and it has to be decompressed. But it's the ones that don't have free air where it's kind of a matter of your own personal view or perspective. And I think in those kids, what needs to be done is we really should randomize them to no surgery at all, no drain, no intervention. Because we don't know, if we just leave them and give them antibiotics like perforated appendicitis, we know that works and they get better. Do we really have to do something? Do we have to be active, or should we just give antibiotics and time and wait? And it's kind of a nihilistic approach. The ones that will survive, and the ones that don't survive, don't survive. And maybe it doesn't matter whether we put a drain in or operate or do, or do a dance. It doesn't matter, it might be.
That's a very important, it is one of these ethical questions. Can you let a child potentially die without even a drain? Is it okay, or any child should undergo a form of surgical intervention?
Nobody shouldn't die without surgery, yeah.
Correct. So another question for you, Oliver, and then I think we are approaching the end of the hour. Do you use any fluid to wash off the toxins inside the abdomen? So when you put your drain, do you do any washout, or you just leave the drain?
I don't, and I've never heard of anybody doing it, but I might be wrong. It might be worth it. I don't know. Do you?
I don't use drains much, but I know that there are some people that think, like for dialysis, that actually that could be helpful. It could be another interesting study to do.
Jeez.
But definitely.
Maybe and maybe chronically, maybe we should just irrigate the bowel for a week. Who knows?
Yeah.
Yeah, it might be an idea.
But then they will absorb that fluid like with peritoneal dialysis and get fluid overload. So the fluid management will be give the neonatologist a headache if you constantly irrigate the abdomen.
But I'm not a nephrologist, but if I'm correct, they can also use fluid, hypertonic fluid that actually pulls off. You could dialyze the kid with that while you're there. I don't know.
Martin, a question for you. During the operation, so you've done your laparotomy, how do you conclude that a segment of bowel is necrotic, except a paper-thin feeling?
Well, the paper-thin feeling, and it's not really dusky. The necrotic bowel is actually either gray or green. So it's really like so dead looking. But still you can almost leave it in if you get a good ostomy upstream, and then you go for a second look laparotomy. So the necrotic bowel actually has to almost fall apart until I take it out.
Okay. All right. Well, I think we can continue forever. This is, of course, a very controversial topic for pediatric surgeons, and I don't think that, unfortunately, any trial will answer the question definitively. I know that Martin Blakely, that you quoted a paper of Oliver, just concluded a trial. They are looking at again in this case drain versus laparotomy, but not looking just at the survival rate in terms of primary outcome, but also neurodevelopmental delay at outcomes at 18 months of age. So it takes a little time to get some results. I've heard some rumors, but it definitely will be, I think, adding more questions than answering all the points, the issues that we have raised. All right, so I think that we can conclude. I don't know if you have any final remarks, Martin or Oliver.
No, I think there was fun. Thank you for moderating this, Augusto. And yeah, no, I think we talked enough, right, Oliver?
Right. Now there were also a lot of questions. I think this is definitely something that is definitely entertaining. Nigel left. He wanted to ask a question, but that's it. Oliver, thank you a lot.
Thank you so much. No, Augusto, thank you so much for moderating, and it was it was a pleasure participating. And yeah, I look forward to seeing you all live again when this COVID is over.
Hopefully in Athens next year. Thank you, Gaia, for setting everything up. It worked well.
Thanks, Gaia.
Bye.
Yeah. Bye. 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 Good night.